Started. Before we get started with Dr. Powell's presentation today, I just want to make a little announcement that we have added another May Grand Rounds presentation by Dr. Jim Park. That's going to be May 22nd, same time, so 6:30. Please join us for that. We'll send out information later. And then to introduce Dr. Powell, we have Dr. Mulligan here.
Morning. Like many great surgeons, Jay Powell was born in New York. Was raised in the Bay Area, went to Berkeley, and then went on to graduate school at the University of Chicago, got his PhD in physiology and biophysics. Was convinced that med school would be the best path for him, so he stayed on for med school at Chicago. Then trained with Claude Organ at UC East Bay and had a fabulous start to his surgical career there, then went on to Duke, and then started his migration pattern that first landed him on the faculty at UT San Antonio, then came up to us in 2013, on to Colorado, and then finally back here. And it's our good fortune now have him as the director of MCS and heart transplantation. He's also the associate section chief for cardiac surgery and the vice chair for quality, wears many hats and all of them extremely well, is one of the finest additions to the faculty we've ever made. And I am very excited to hear about his talk today, which is centered around everything you ever wanted to know about ECMO, but didn't know who to ask. So Jay, as we ask.
Thank you, Mike. That was very kind. All right. So everything about ECMO that you always wanted to know. I recognize that this is a very specialized therapy in a very specialized field. So please feel free to interrupt if there are things that I gloss over, go too quickly that would be worth spending a little bit more time on. I really got interested in ECMO kind of halfway through the first year of my cardiac residency. And the reason is that the complications and the therapy was so unique and so interesting in how it affected the patient's physiology. I mean, there aren't many things where you have a parallel or series circulation in addition to the patient's own circulation. And I found this somewhat related to what I studied in grad school, but in grad school, when you have circuits, everything's either parallel or it's a series circuit. And ECMO and MCS in general creates this kind of variable state where the function of the circuit and the function of the patient are very intimately involved. And that was one of the real reasons that kind of drew me into heart failure and transplant surgery in the beginning. So we'll spend a little bit of time talking about how and why we use ECMO these days. We'll learn the components of an ECMO circuit and understand when we should apply this therapy and when we shouldn't. If you've been reading the lay press, you'll know that ECMO is having a moment. It has been in the New York Times, the New Yorker, and other publications quite a bit lately. There's lots of interest in this therapy that has been around for over 50 years, but really seeming to have a resurgence, especially in the adult population. Lots of pictures of people without hats and masks doing sterile procedures in Minnesota, but it gets you in the New York Times. So I'll back up for a second. ECMO and ECLS are the same thing. The term ECLS is probably more applicable, so extracorporeal life support, but ECMO rolls off the tongue a little bit better. So we talk about extracorporeal membrane oxygenation, and the membrane oxygenation is the oxygenator part of the ECMO circuit, which I'll show in a second. Like I said, ECMO started about 50 years ago by Bob Bartlett. He was a faculty at the University of California where he initially started the research on extracorporeal circulation and ultimately applied the therapy in 1975 to a child with meconium aspiration. At that time, neonatal respiratory distress syndrome had a mortality rate of about 80%. And over the subsequent 15 to 20 years, the survival is now much greater than 80% because of the applicability of ECMO to this patient group. Interestingly, this child's nickname was Esperanza, which means hope. So I'll start with a clinical scenario that we may see pretty routinely. This is prior to COVID. So this is a 35-year-old woman who presented with a week of upper respiratory infections. She ultimately presented to the emergency room, was hypoxic enough that she got intubated, and her workup demonstrated that she had H1N1. H1N1 is actually one of the largest growth periods of adult ECMO prior to COVID. Prior to the H1N1 pandemic several years ago, adult ECMO was pretty much limited to post-cardiotomy or post-thoracic surgery usages because the outcomes for cardiac failure and respiratory failure were so poor. In any case, this patient says external display disconnected. I can keep going. So the patient got worse. Continues to be on maximal ventilatory support, a beep of 20, FiO2 of 100%, and was ultimately proned, but started to become hemodynamically unstable from the hypoxemia. Gas is shown here, both hypoxemic and hypercarbic and maximum vent settings. So when presented with a patient like this, there's few options. One of the things that could be considered would be inhaled pulmonary vasodilators, epoprostenol, or inhaled nitric oxide. Unfortunately, in cases like this, that usually has minimal utility. So the most likely therapy that would be thought of, especially given this talk, would be ECMO. But before we proceed to ECMO, I think it's one of the things that, thank you, just say it again.
Yeah.
Okay. So before we think about ECMO for any particular patient, one of the important things to consider is what you're going to do after ECMO. And, ECMO does not treat the lungs in these circumstances, but it does allow the patient to become stable until you make a decision if the lungs can recover or be replaced with a transplant. And I think this is one of the most critical things anytime we think about any patient that may need extracorporeal support is what the exit strategy is going to be. So like I said, ECMO itself doesn't treat. It simply allows stabilization of the patient while the underlying condition is being treated. So these are the main components of an ECMO system. The patient's venous blood is drained through a large cannula. It goes through a pump. An older roller pump is shown here at the bottom of the screen. The pump then pressurizes the blood, moves it through a membrane oxygenator, which is connected to a gas blender. The blood then goes through a heat exchanger, which can either warm or cool the blood and then pump back into the patient. The important parts of the O2 blender or the gas blender is that it functions very analogously to a human lung. So you can control the FDO2 or the fractional delivered oxygen, and you can control the sweep, which is analogous to the tidal volume. So you can independently control the patient's carbon dioxide level by increasing the sweep, just as you would increase the tidal volume on a ventilator. And you can adjust their oxygenation level by increasing their FDO2 on the circuit. There's obviously some interplay with the pump flow, just like a patient with a low cardiac output state would be relatively hypoxic and relatively hypercarbic. So the interplay between pump flow, oxygen delivery, and carbon dioxide extraction is some of the nuances of managing these pumps. And one of the things that I found most interesting early on in my residency. Like I said, the diagram showed a roller pump. This is what we typically use. These are centrifugal pumps. So the blood comes in at the top of the pump. There's a cone that's spinning between 3,000 and 5,000 RPM. And because of centrifugal forces, the blood gets forced out downwards from the pump and then onto the oxygenator. There's a variety of oxygenators available on the market. They look all some combination of a membrane which allows gas in on one side and out the other side and blood going in a countercurrent direction. And this allows gas exchange, both oxygen and carbon dioxide. And like I said, the sweep rate determines how quickly the exchange occurs. The blood spreads out across these membranes, very similar to the alveoli. These systems can be all in one, such as this CardioHelp system. These are pretty easy to use. Everything is integrated, the pressure sensors, the controls. The oxygenator is the red device that you can kind of see in the back. And there's just a handful of tubes that come out of it and that are connected to the patient. This systems like this that are integrated are very easy to use for transport, also very easy to prime and deploy pretty rapidly. So back to our case, the patient was hypercarbic and hypoxemic, but her heart was working well. So this patient would have been supported with something called VV ECMO or veno-venous ECMO. And in this case, the purpose of the ECMO circuit is simply to oxygenate the blood and remove the carbon dioxide. It doesn't provide any circulatory support. So the general idea is that the blood is removed from the right atrium, it's oxygenated and then put back into the right atrium, just distal to where it's being drained from. So the idea is that there is no parallel circulation, but an additional pathway for blood to become oxygenated and then be pumped through the patient's natural circulation. And so the blood that goes into the pulmonary artery, which normally would be deoxygenated, is now oxygenated. It goes through the lungs, which aren't functioning, and then pumped out into the aorta as oxygenated blood. There's a variety of ways that a patient can be cannulated for this. A common way is femoral-femoral, so it's drained out of the one femoral vein and returned via the other femoral vein. A more modern mechanism is using a dual lumen cannula. There's a couple of versions known as an Avalon or a Crescent, and they drain from both the SVC and IVC and return blood into the right atrium. And these tend to be a little bit more efficient. They can have very high flow rates, and they avoid some of the potential recirculation issues that can occur if the outflow and inflow are close to each other. There are obviously some challenges placing such a big catheter. Crescent cannula goes up to 31 French. So when you place that in the neck of a patient, there's obviously the risk of some vascular complications. As you know, some patients with respiratory distress will develop right heart dysfunction. That's not shown up very well. But there is a dual lumen cannula that's meant to support the right ventricle at the same time. The cannula is placed through the right neck, similar to the dual lumen cannula that I showed on the previous slide, but the outflow is now in the pulmonary artery, so the entire right heart is bypassed and oxygenated lung is drained from the right atrium and returned into the pulmonary artery. And this can be described as VP ECMO or RVAD ECMO or RVAD oxy, variety of different terms, essentially suggesting that you're supporting both the right ventricle and the lungs. So back to this patient, was on ECMO for 11 days, had subsequent improvement in lung function. Throughout the 11 days, the patient was cannulated initially through the groin and then through the neck, and then was able to ambulate and rehab while on ECMO. And it was one of the reasons why they were able to discharge home relatively soon after being decannulated from it. So we talked about ECMO for respiratory failure, but in the US, the most common reason for ECMO is acute cardiac decompensation. Myocardial infarctions are a common source, and that's what the Minnesota program that I showed in the New York Times article is based on, is applying ECMO for patients with post-myocardial infarction cardiogenic shock. Post-cardiotomy failure is another common use. This is when the patient has a bypass surgery or a valve operation, they can't wean from the heart-lung machine. And we can put them on an ECMO circuit, which is essentially a scaled down version of the heart-lung machine. And then there are more planned or convenient forms of ECMO, so procedural support. Sometimes a patient will need a coronary intervention or an IR procedure, such as a suction embolectomy for pulmonary embolus. In those cases, the hemodynamics may need support with an ECMO circuit, or something like airway surgery, where a carinal resection or tracheal resection, ventilating the patient becomes difficult, and so using ECMO in those circumstances can make the operation a little bit easier. Like I said, most ECMO in this country is done for heart failure. This is an example of a patient that Was subsequently supported with ECMO, as you can see on the left side. That's an injection of the left main coronary system. There's a very tight stenosis in the distal left main, very poor runoff in the distal coronary beds, and leads to biventricular dysfunction. So this is a patient that most people would think would be well supported with ECMO. But again, before ECMO is initiated, it's important to think about what the exit strategy is. Patients with myocardial infarctions can often recover with periods of ECMO support, where the left ventricle is decompressed. But if they're not, they can usually be managed with inotropes. And if their ventricles are too bad, then an LVAD or a transplant is an option. So if you believe that the patient has one of these exit strategies, then it'd be appropriate to place them on different form of ECMO, essentially the same pump as I showed in the previous circumstance. But this is VA ECMO or veno-arterial ECMO. And the difference in this case is that the venous blood is drained from the patient's right side of their circulation, but instead returned to the arterial tree. So in this case, in this diagram, in the femoral artery. And in this is very similar to the bypass machine we use in the operating room, in that the blood is bypassing the heart and lungs altogether and returned to the arterial tree. So when the blood is pressurized through the ECMO circuit, this is what provides a systolic or systemic blood pressure in a patient in cardiogenic shock. As you can imagine, putting a large cannula in a femoral artery can cause some distal vascular complications. So it's not unusual that a patient may need a distal perfusion limb. Working. So, right, this is the arterial cannula. It's 14 French in this case. In a small patient, it may be occlusive. So there is this 5 French antegrade cannula that provides blood to the leg distal to the arterial cannula. So a patient on VA ECMO can be pretty challenging to manage. The flow rates should approximate their normal cardiac output to ensure organ perfusion. The oxygenation is similar to VV ECMO, meaning the FiO2 and sweep are managed similarly. But it's important to recognize that when you're draining from the venous system and returning to the arterial system, you can't reduce the sweep and the oxygen completely like you can on a VV circuit. As a patient improves, they're going to have a large shunt because they're draining from the right side and returning to the left side of the body. And monitoring hemodynamics is important. All of these monitors that we typically use in cardiac surgery or in the CT-ICU are applicable in these cases, but with some caveats. All of these numbers tend to be a little wonky simply because of how the blood is flowing and where the cannulas are, and they can impact pressure readings in different parts of the heart and so on. But as shown in this picture, sometimes a patient recovers their heart function and they start to become pulsatile, as you can see on the arterial tracing. That's usually a good sign that the heart is starting to improve after some period of rest. That does sometimes lead to an interesting circumstance when a patient has a recovering heart, but still poor functioning lungs. And this is known as north-south or Harlequin syndrome. And I remember seeing this on the first patient I ever took care of as a fellow on ECMO, and I just couldn't understand why the patient looked gray up top and legs had great pulses and were warm and well perfused. And this is an interesting phenomenon that occurs when the heart starts to recover and the lungs continue to be dysfunctional. And the reason it occurs is that an ECMO circuit, unlike a bypass machine, doesn't completely drain the patient's venous return. So some amount of blood, 20 to 40%, can continue to bypass the ECMO circuit in a VA system. And that'll go through the RA, RV out to the lungs and then essentially get ejected to the ascending aorta. And in a patient with poor respiratory function, blood does not get oxygenated in the lungs. And then when the left ventricle ejects that blood, it tends to be relatively deoxygenated. That's in contrast to the blood that's going through the ECMO circuit, returning to the femoral system, and that blood is highly oxygenated. And so what you end up with is a mixing point where oxygenated blood from the groin is going retrograde, deoxygenated blood from the heart is going antegrade. And that mixing point is where the patient develops this north-south distinction. And there's a variety of ways to manage this, but in a patient with a recovering heart and dysfunctional lungs, this is a problem that we see not infrequently. And we end up having to make some adjustments to the flow, either to push the mixing point more proximal with the ECMO circuit or increase oxygenation of blood going through the lungs. Years ago, that would have been done by either centrally cannulating the patient or providing the arterial inflow through the axillary artery, as shown here on the right. And what this does is it puts the oxygenated blood into the proximal aorta, and it avoids this issue of the north-south of the Harlequin syndrome. These days, we tend to not do this quite as frequently. We tend to use some kind of triple cannulation strategy where VVA or veno-veno ECMO, veno-veno arterial ECMO, or veno-arterial venous ECMO. These are just different ways of draining blood from some parts of the body and returning it to a different part. So in VVA ECMO, there's two drainage systems. The idea is that you would drain all the deoxygenated blood more effectively from the patient, so there would be very little to go through the heart and dysfunctional lungs, and it would still be returned as described previously. Whereas on VAV ECMO, the blood is drained from the venous side and then returned both into the venous side and to the arterial side. And in this case, some of the blood is going to support the patient's systemic perfusion, and some of it, the part that's shown up on the top on the right schematic, is returning oxygenated blood into the right atrium. The idea being that this blood then goes through the lungs, just like traditional VV ECMO, and then the blood in the ascending aorta is then oxygenated again. As you can imagine, this can create all sorts of challenging circumstances where the return may be greater than the arterial can support, or vice versa on the VAV side. You may end up having to rob Peter to pay Paul to improve oxygenation at the expense of systemic perfusion. With all of these, ECMO is almost always the therapy of last resort. Given the challenges of this therapy, the large cannulas, and how sick these patients are, we almost never think about this until almost all other therapies have failed. ELSO is the Extracorporeal Life Support Organization, kind of maintains a database of all ECMO throughout the world from participating centers. And it's a very interesting site that you can log in and take a look at current volumes and outcomes and so on. But the survival on ECMO largely depends on why you deployed the therapy in the first place. There aren't a whole lot of things that you can do within ECMO itself to make the patient better. And so post-cardiotomy failure still lands up with a 50% survival. Doesn't really matter what type of ECMO you do in these patients. I did mention complications of ECMO. This is a very morbid therapy. You know, a very common outcome is that patients simply can't be supported adequately and they expire from their underlying illness. But stroke is a common occurrence as well. These patients are anticoagulated. They tend to have microemboli. You can have post-infarct hemorrhagic conversion in the brain, or in some cases, a patient had a stroke during the initial arrest that led to the ECMO. It's not apparent, and so they're put on support afterwards. And you can imagine circumstances like these can create devastating outcomes. Limb ischemia, I had mentioned earlier, is something that occurs because of the large cannulas that are placed in the femoral artery and vein. Usually that's something that is monitored pretty regularly, and we can take steps such as perfusion cannulas to prevent that. And hemolysis occurs because these pumps pressurize the blood to about 300 to 400 millimeters of mercury pressure, and then is pushed through a narrow membrane oxygenator, cause some blood damage, which then further worsens the bleeding and renal failure. Management of these patients is highly complex. It kind of centers around the ICU nurse and the ECMO specialist, who's typically either a nurse or a respiratory therapist. Perfusionists are usually involved, as are the surgeons in the cases of circuit exchanges or reconfigurations, and so on. And of course, cardiologists and pulmonary physicians to treat the underlying conditions. So when a patient gets put on ECMO, assuming they survive, they don't typically go home 5 days after an ECMO run, as happened in the first case. There's a prolonged period of physical therapy and occupational therapy that's often required. There's a general rule of thumb that it takes a week to recover from a day in the hospital bed. So these patients that can be on for weeks or months at a time can have prolonged recoveries well over a year long. And many of them land up with such muscle and neuropathic injuries that they struggle with many of the activities of daily living. You'll hear on Friday at the visiting professor about some of the quality of life issues that we've tracked in our patients. Many patients have PTSD after ECMO runs. Many of them have chronic pain issues, and they're still recovering a year later. So to ensure the best ECMO outcomes, it's critical to choose the right patients. This is something that with years and decades of experience can still be difficult to do. It's very easy to want to apply the therapy to patients that are young, otherwise healthy, but a lot of times the circumstances on which we're asked to put a patient on ECMO can make it very challenging to get a good outcome. Technical competence is key when you're placing large cannulas, somewhere between 15 and 30 French in these vessels. And so vascular injuries can be very common, and in some cases, a poorly placed cannula can lead to a devastating outcome. It can lead to a retroperitoneal bleed or an injury in the mediastinum. Having an ICU team that's familiar and comfortable with the care of these patients is really important. The protocols for managing them is key. Even simple things that you take for granted, like placing a patient on a ventilator with the head of bed at 30 degrees, which is standard in every ICU, becomes difficult when they have large cannulas in their arteries and veins. It's very difficult to roll them, to do normal daily hygiene and so on. And it's important to constantly manage and evaluate outcomes. These are highly morbid patients, and like I said, survival kind of varies between 40 and 80% depending on the circumstances. And so small changes in practice patterns can have outsized effects on overall outcomes. I mentioned patient selection. The criteria for initiating ECMO, I think, is constantly evolving. In that New York Times article, the group essentially is cannulating any patient that presents in cardiogenic shock after a myocardial infarction anywhere in the city limits and anywhere regardless of how much time they've had CP. Our protocols are a little bit different here, and we have a very discrete time period that we want from the initiation of chest compression to the initiation of ECMO support. If it falls outside our window, the outcomes we feel are so poor that we won't apply the therapy on those circumstances. The contraindications are constantly changing. I talked most significantly about an exit strategy. If you don't have one, that should be an obvious contraindication to ECMO. But there are other things. Patients with severe vascular disease often can't have these cannulas placed peripherally. They may need central cannulation, which leads to another set of challenges. Neurologic status, the code that led to them needing ECMO can cause neurologic injury, or if they have some other comorbidities or even advanced age. These are things that we would think about, because the older a patient gets, the harder it is to get a good outcome. We typically will go up to age 70 with ECMO. I'll tell you, a 70-year-old on ECMO acts their age real fast, acts older than their age real fast. The typical option, as I mentioned, for ECMO is that it's a therapy of last resort. And once a patient starts failing medical therapies and they start decompensating towards this point of inevitability, that's usually when an ECMO consult is called. And unfortunately, at that point, this trajectory is predetermined. So it's nice to be able to apply the therapy to patients that have started their slide but haven't gotten too far and haven't really crossed the line of being unsalvageable. This is often hard to do. And I don't know how many hundreds of patients that I've seen on ECMO over the years. I don't know that I can still pick at the time of cannulation if I can predict who's going to survive and who's going to have a good outcome, but still working on it. I'm going to spend just a couple of minutes talking about the ethical considerations of ECMO. This was an article in the New Yorker recently. I will also mention some of the drawings here were made by ChatGPT, and actually used ChatGPT to ask what topics I should cover in a talk on ECMO, and it suggested ethics. So there it is. I wouldn't have thought about it. It wasn't in my original presentation that I uploaded. So there's a couple of interesting points from this article. They talk about the technology of ECMO is far ahead of the ethics of ECMO. And that ECMO creates a precarious form of existence, which sometimes raises questions about our traditional definitions of life and death. Without ECMO or extracorporeal circulation, if a patient's heart stops or their circulation stops, we would call that dead. But that would have some finality to it. It's not necessarily the case when you have ECMO in patients that can be dead by all other criteria, or even dead in one hospital can get moved to another hospital and not be dead. And that creates a lot of confusing circumstances and also some confusing expectations. And certainly been in cases where I've been asked, why wasn't ECMO applied to this patient? As if it's almost standard of care. And I don't know that we've gotten there, but it certainly may be. And with the New York Times reporting that everyone in Minnesota is eligible for ECMO, we may be getting there. So along those lines, there's a couple of questions that I've heard about ECMO that are really interesting. This is a very recent one from an ethicist that I've worked with. A heart becomes asystolic with a patient on ECMO. Is the patient technically dead? And this came up from a chapter in an ethics textbook about managing patients on ECMO. And the conundrum was that the physicians taking care of the patient said the patient was asystolic and therefore they should be dead and the machine should be turned off, but the patient was apparently moving and interacting. So that the question that the current definition of death doesn't really address. This is one I heard when I was a fellow. I placed a patient on ECMO, went on a procurement, came back, and another fellow asked me, well, I think the patient died, but he's still on ECMO. I can't really tell if he's dead. So that is not uncommon, unfortunately. And the last one, which we often hear about, can't you just put them on ECMO when someone's in a very precarious circumstance? And this is one that is challenging for a variety of reasons, because in the heat of the moment, someone's getting CPR. It's really hard to make these types of life and death decisions without knowing very much about the patient. And all you're seeing is someone getting chest compressions. Sometimes the family's outside and they're young, you tend to want to do more. And if you know something about the patient, that may be helpful, but oftentimes we don't. So this sometimes leads to some of the most complicated circumstances we see in our ICU. The patient is on ECMO, not survivable, but not dying either. And this is an area of ECMO that I think probably land up with much more discussion, debate over the upcoming years. All right, so I don't want to end on a kind of Debbie Downer note. So a couple of positive outcomes. This is the quiz. If you can identify which of these young women was on ECMO for 9 weeks. I'm sure you're all good test takers, so the leg immobilizer and the crutches are a distractor. Any guesses? Going left to right, 1 through 4. Middle, 2. 2, because you can identify the cannulation site in the tracheostomy. Yeah, she's now a physical therapist after a lung transplant. And then the ECMO I showed you, or the echo I showed you earlier, the lady cardiogenic shock with spontaneous coronary dissection, shown here on the Life Center Northwest annual report after being on ECMO for 2.5 weeks and then being transplanted.